Morning, everyone, and welcome to the Resuscitation Quality Exchange call. My name is Audrey, and I will be your moderator for today. Feel free to ask questions throughout the presentation by typing them in the Q&A section on the right hand of your screen. The slides and links to the presentation will be sent out within 1 to 2 weeks of today's presentation. I will now turn it over to Cherie, our Senior Director for Quality.
Good morning, everyone. Welcome to the Quality Exchange. As you know, we have these each quarter for each of our modules. Yesterday, we had heart failure first thing in the morning and stroke over the noon hour. Today, resuscitation, and at noon, we'll have atrial fibrillation focused. And then tomorrow morning is the coronary artery disease, or CAD, Quality Exchange. So pass it along to your colleagues that these are available. They are not only for Get With The Guidelines customers, but we're happy to have folks who are considering Get With The Guidelines or who aren't using it but would benefit from some of the updates we have. So we'll jump into today. We have a small group today, but you'll be able to pass this along to your colleagues as well. All right, let me get, all right, here we go. So this is we have a pretty packed agenda, a lot to share. And so we'll jump right into that. I want to let you know that each of you should have received a second quarter data days update from your Director of Quality. And we do this every quarter. The directors for the Southwest region, 6 states involved there, we take that week to send out updates to all of our customers. We know that you diligently put in data, but you don't always have time to run all your reports. So you can expect that once a quarter we'll do that, and we'll show you where you are as it relates to on track or not on track for recognition. So you should have received those reports. If you did not receive it, it's possible that someone else in your organization did. So, and you want to be on the list, just email us. If you know your director, you can email her. But if you don't, just send an email to swaquality@heart.org, swaquality@heart.org, and we'll get you lined up with your director and make sure that you are added to the quarterly performance updates. So, you know that our whole goal and why we're even on the phone today is that we want to be able to improve survival to discharge for our cardiac arrest patients. And so there are a number of things that are in those quarterly reports. Now, this is kind of an overview, but they're very important. What I'm seeing is I'm looking at all of your reports that we have a lot of high-performing hospitals, but some of you who've just started or have a low number of patients are having some difficulty on the time to shock, which is to be less than 2 minutes. And so don't forget that your director is glad to help you, to connect you with other hospitals that are able to, who've over time met this measure, and we can help you work on that. But I still see that there are a few hospitals that have some long times to defibrillation, and when I say long, you know, in the 3 or 4 minutes. The data is very clear that survival is directly related to the amount of time between you determine the need for CPR and them being shocked. So continuing to work at that. Almost all of you are doing a good job as it talks about making sure you don't have unmonitored patients, making sure the patients are in the proper level of care, that people aren't being discharged to or moved to step-down units too early, that patients are being kept in those ICU, those high observation locations if they are at high risk. Time to chest compressions, while that's not an achievement measure, and I'll show you later in a study, is very important, particularly in our pediatric patients. So that's an important element, as well as decreasing the time to epinephrine. And then, of course, the tricky one, the one that was added last year, I think maybe the year before that, having documentation that the airway was confirmed at each step of the patient's movement. So while they may have been intubated in the emergency department, that airway is confirmed when they move to the ICU, and that information is documented. And I think it's really that documentation piece that is throwing off some of you. So again, we're glad to work with each of you on the areas where you may not be on track. This was only Q2 data. There's a good amount of time to change processes and to improve care during this year. So work with your director. We're not there just to give you the data. We're there to help you improve it. And again, that's available at no extra charge to you. It's included with your Get With the Guidelines. So I did want to talk and remind a little bit about the sixth element of improving survival to discharge, and that is CPR quality. And some of you may know and some of you may not know that, go ahead and get this whole thing up here, that the American Heart Association introduced a program in 2014 called RQI, Resuscitation Quality Improvement, and the concept of the RQI is to make sure that we have ongoing practice and maintenance of competence with CPR. So basically, we're trying to change an entire culture across the world and go from having a card every 2 years to going from certification to having competency. So we want you to be competent and confident in your CPR skills. So I know there may be some on the phone who have RQI. With RQI, you basically have this kind of a cart that is put around your facility. A small hospital, a community hospital might have one of these. A large urban center might have 14 to 16 of these in the hospital. And the concept is that the entire curricula for CPR, BLS, ACLS, PALS, has been divided into 2 years. And so you just once a quarter go to the mannequin, demonstrate skills, go to the computer, finish a quarter of the didactic work, and then your electronic card is actually forwarded another 3 months. So you aren't working toward a 2-year certification, you're working on a quarterly process. So if any of you are interested in this and want to see what this involves, please email us at swaquality@heart.org or let your director know that you'd like to see this and see what it would mean for your organization. Most hospitals save money doing this method. You don't own these carts. You're actually just paying a rate per trainee. So they actually save money. The staff doesn't have to be off the unit to get their training. Nobody has to replace them, and you don't have to run CPR classes for your own staff. So I encourage you to think about this, because when we talk about the things we need to do in this country to improve survival to discharge, and remember the average is still running, it was at 19%, but I think the average has improved, but only to 23% or so. So we still have a long way to go with our goal to double survival by 2020. Our goal was to get to 36%. So there's still a lot of room to go. I don't believe we have the audio today, but are there any questions related to RQI? You can type them in, and then Audrey, interrupt me at any point if we have questions, or we're happy to have comments too, or if someone would be interested on a future call of talking about your experience with RQI, we'd love to have that maybe in the next quarterly. So type that information in. Anything there right now, Audrey?
No, not yet.
All righty. So moving along. Oh, I did just want to show you. This is a study that showed the CPR skills decline, and this is what we used to do, right? So you get trained, and then we train you every 2 years. You can see that during that 2 years when you're waiting for your certification, your skills are actually declining. And we all know that most people are not doing CPR every day in the hospital. Most of your staff is not on the code team. Most of the staff is not in the ICU, and so they don't even get the opportunity to do it in person. So this is what RQI takes care of. And this is an example of the credentials that people get when you are an RQI site. And I want to point out that one to the top right, that's called an RQI responder. We've added this to the opportunity, and that is so hospitals can have their non-clinical staff actually participate annually and do hands-only CPR. And of course, they can practice anytime, but we want to start introducing CPR and especially hands-only CPR to our non-clinical staff. So that's called an RQI responder. All right, this is great news. Some of you may be struggling at getting your data in, and you're saying there's so many data elements in Get With the Guidelines Resuscitation. We're in favor of it, but we just can't get them all in. Well, what has come along with RQI is we've created another version of the module, and it's called Essentials. And it means you only are completing the CPA tab, and you're familiar with that, those of you who abstract, inside the module. You'll still be eligible for recognition. There are fewer data elements, and this is available for all customers. So if you're struggling, talk to your director about perhaps switching to this more focused tab. Now, those of you who are already doing it and getting a lot of good data as it relates to the other, this will kind of chunk that down. You won't have as many data elements to investigate. But for those who are having difficulty getting started, this is a great place to start. And just so you know, if you're an RQI customer, Get With the Guidelines Resuscitation is available at no charge to you. You still fill out the PHA, you fill out an agreement, but you will not be invoiced. So if any of you are RQI sites, just double check that we've got that on our list so that you are not being invoiced for Get With the Guidelines Resuscitation. It is available and included with RQI. All right. Well, participation continues to grow and Get With the Guidelines Resuscitation. I will say that it's still frustrating that we have so fewer number of participants than, say, stroke, because the issue of cardiac survival is so important at every hospital, regardless of the size. But we do continue to grow, and so you can imagine that the data that comes out of Get With the Guidelines Resuscitation is good data. It's not based on just a few patients. It's based on very many. And we're continuing to grow, improve survival to discharge. This is all adult pulseless rates, although I'm never a big fan of the top of the chart being 25%, but you can see that while it has been low, we are making some inroads. That's adults. And here's your, when you divide it up by the type of rhythm. So even in asystole and PEA, and probably the majority of those are PEA, we are seeing an improvement in survival, where previously you might have thought those are patients that aren't going to survive to discharge. And then when you look at your shockable rhythms, the top group continuing to improve. So thank you for being committed to improving your cardiac arrest survival. Very important. And here's your pediatric data. Now look at that, you know it's significantly higher. We're wanting to double that number also, but we're wanting to double that. I believe the double is to 60% because it's currently around 30. So we are making more progress on that. And for some reason, our children's hospitals are making more inroads and interventions than our adult hospitals. With that in mind, those numbers I showed you are non-risk adjusted. But because of your participation in Get With the Guidelines Resuscitation, you have access to a risk standardized cardiac survival report that's personalized for your hospital. And I'll tell you, this report is actually worth more than the module itself. Many places might have consultants actually go and try to investigate this for you, but you have it included in Get With the Guidelines. And what they do is they take your annual data and they pull it out and they run it against 9 variables for adults. So the variables here are age, of course. We know as you are older, you're going to have a higher risk of not surviving, of what the initial cardiac arrest rhythm is, of where the patient is when they have their arrest, whether they have low blood pressure, sepsis. You see these different things if they already had cancer and so they were working with that, as well as what's going on with their other systems, if they've been on a vent, and if they're on a vasopressor. So all of these things are indexed into a very complicated algorithm, which we're glad to share if you want to look at it in order to determine risk standardized survival. On the little kids, on the kids, it's 13 variables. So on kids, again, it's age stratified. We know that male tiny babies do have a less chance of surviving. It looks at whether they have cardiac issues, again, blood pressure, looking at the kidneys. As you look down through there, these things are not surprised. Of course, if they've had a trauma, that increases their chance of not surviving. So this is the information that's put into your risk standardized survival report. Now, before we introduce this, I think in 2012 or 13, this is how unadjusted survival looked across the Get With the Guidelines resuscitation. And any of you should know that that isn't how we would expect survival to look. We weren't comparing apples to apples. But when we have risk strategized and looked across the country, then this is how that survival rate looks across the U.S. And you know that when you have that bell curve, it gives you some idea that you actually are doing a proper comparison. So where do you find this? You go to your home page, down in this section called My Reports. You may not even have ever looked at this. And then under there, you're going to see this Get With the Guidelines, Risk-Adjusted Survival to Discharge Report. And this just was put out there, I don't know, May or June, so it hasn't been there a long time. Based on 2018 data. When you open it up, it looks like that, and you go ahead and click on that. And this is kind of how it looks. So you will have separate reports if you do pediatric. The pediatrics have been all hooked together. They're not separate by age group. We just don't have enough. So you would have adult and pediatric. I believe pediatric also combines 2 years to make sure you have enough in. But what this will do is actually give you your hospital's risk standardized survival. And if you've been in several years, you'll get to see those over time. And then it'll give you a survival quintile of where you are performing. It also gives you a pictorial look at kind of what does it look like, what's the highest in the country, what's the lowest, that there are hospitals that are in the 10%, and there are hospitals that are at 35, and then show exactly where you fall in that, and then how those quintiles lay out. This is just like your kid's standardized test or the test you took in school, where if you are in the top quintile, if you are 5th quintile, that means that your survival rate is better than at least 80% of the hospitals. And if you're in the 3rd quintile, yours is better than 40%. So again, we talk about quintile performance. This is what you'll have for your very own hospital. So I encourage you to pull these down. If you want your director to walk through it with you, we're glad to do that. We can also help put slides together, or for you to be able to present this so you're comfortable with it, because your physicians will be very excited to see that they have this information. They will also be interested in seeing how you've done over the years, because you can see 2014 through 2018. I will tell you that it's very important for our clinicians at the national level that we eventually get a nationally publicly reported survival rate included on the, on Hospital Compare. And we are working diligently to make that happen. And in fact, several of our measures are with the National Quality Forum, and that's the first step to getting a core measure evaluated by CMS and by other organizations. So work on this now. Be in the top quintile so that when that happens, there's no concerns about what's publicly reported. Any questions on the risk stratified survival report? Feel free to type those in if there's any questions. And we can always come back to them, but feel free to put those in there. And while you're doing that, just a reminder, when you Get With the Guidelines resuscitation, you can have up to 10 users. The users that put in data, of course, have to be certified as abstractors, so you have to take a little test. But you might only have 1 or 2 of those. you can have 8 or 9 other users who are observation only. They can run reports. This is great for your leadership. It's great for the quality department. It's great for the folks who aren't abstracting, but so that they can run reports out of it and include it in other dashboards. However, in doing this and having 10 users, we have discovered that some hospitals aren't carefully removing those users when people change roles or worse, leave the organization. So when your director pulls up your users, they can see every user on your hospital. And so we want to make sure we don't have resigned or terminated or retired folks on your list. So if you will send a list of the users who should have access to the PMT, and you can reply, if you've got your quarter 2 update, just reply to that and say, my users are this, and give those names and email addresses, then we will make sure the users who are not correct are removed. If you just want to do this on the phone, just buzz your director or email them, and they'll be glad to send you a list of everybody who currently has access so we can keep that up to date. So this is just, while there's not PHI out there, this is for security. We want to make sure that you're keeping your users up to date. All right, well, I just talked about public reporting and that we're working on public reporting, having it being a requirement. But in the meantime, many organizations, certification organizations, recognition organizations like U.S. News and World Report, payers like Blue Cross, accreditation organizations like the Joint Commission, DMV, HFAP, are requiring hospitals to publicly report their quality data. And previously, while you could publicly report that you were a Get With the Guidelines Resuscitation Gold, we didn't have an option for you to actually report your results and to tell the public how well you're doing in this category. If you are interested, we are now making it possible for you to publicly report your numerators and denominators for the achievement measures, so only those top 4 measures. And there was a survey that went out. If you didn't see this or aren't familiar with this, and you think you want to be involved, let your director know, because there will be another chance. Phase 1 ended last Friday, but there'll be a second phase of public reporting sign up. There's, of course, no charge for this. This is just putting in our quality page and letting consumers increase their awareness of how hospitals around them are doing. So I think I mentioned these bullet points, but it's an opportunity so you can improve consumer awareness. If you're reporting these things, you're all out there and you want them to know how you're working on it. It gives us the opportunity to eventually include these in the U.S. News and World Report Index, to get credit perhaps from health plans because you're using voluntary public reporting, and of course meeting some requirements for your accrediting organizations. If you have questions on this, type them in or reach out to your director. Like I said, there'll be another opportunity to do this coming up soon. The primary contact was probably your contracting contact who received the email in the first phase. We want to make sure in this second phase that everyone gets the opportunity to do this who wants to do it. So please let your director know, or if you don't know who that is, swaquality@heart.org. Also wanted to just let you know there's been some changes in the certifications that are available through American Heart Association, where you have the opportunity to achieve the heart check mark. We know that the American Heart Association brand is one of the most recognized brands, not only in the country, but in the world. So as your hospital participates in these certifications, your patients will know what that heart check mark means, perhaps more than even the Joint Commission placard, which of course all health professionals know. So I wanted to just get you update real quick on what's out there. These don't directly connect to resuscitation, but I know you all work with these programs. So there is the advanced certification in heart failure. This is an interesting one, the post-acute care heart failure certification. You may or may not know that many of the patients who come to our hospitals with heart failure are residents in skilled nursing facilities. And some of the new payer models allow hospitals and nursing homes to work together to minimize readmissions, and then if they have extra money left over, to be able to share it. It's called a bundled payment model. So we have a new skilled nursing certification, which is called PostAcute Care Heart Failure Certification. So finally allowing those really high quality, forward-thinking nursing homes to show the kind of work they've done, because I assure you the majority of their patients do have heart failure. And these just came out on July 1st. We'll now have a full series of heart attack certifications. So primary heart attack center, which is going to be for those hospitals that do have cath labs and are providing that service 24/7. And then also acute heart attack ready. So those are going to be folks who maybe have a cath lab that's only for elective, or for your small hospitals, your community and critical access hospitals who want to be ready. They don't want people to drive past. They want people to use 911, and they can demonstrate to their community that they can comfortably come to them for that first phase when they're experiencing chest pain, et cetera. So acute heart attack ready, primary heart attack, and then of course comprehensive cardiac center certification. And then these align with the stroke certifications that are also available: comprehensive, thrombectomy capable, primary, and acute stroke ready. So it doesn't completely relate to what you guys are doing, but I do want you to be aware that they're out there. Audrey, any questions?
Not yet, Sheree.
Okay. Want to just tell you a little bit. This is the point of the program when I like to be able to just give you an opportunity to see what research is out there, and give you, I know you want to look at the research related to resuscitation, but nobody really has time for it. So a few pieces of research. The first ones come from Get With the Guidelines. So this was a study looking at the association of hospital rate of delayed epinephrine administration. Remember, we talked about that. That's one of the pediatric measures that we're looking at, and for non-shockable cardiac arrest. And what they found out was that delayed epinephrine administration, and remember it's 5 minutes or less, following pediatric non-shockable in-hospital cardiac arrest, it varied hugely across hospitals. And that seems odd. It's a class 1 recommendation. We really need to make sure that your algorithms, that your EHRs are indicating that. Hospitals with a higher rate of delayed epinephrine administration had worse patient and hospital level outcomes. And that's after they adjusted for how sick the patient was. And so delayed epinephrine administration directly contributes to increased mortality risk and could be a marker for a hospital's performance. So go back, look at your data, look at it over time. Your director can help you do this and see how you're doing on time to epinephrine. This was on pediatric, but I encourage you to look at it for your adult population as well. Look at it since you've been working on it, and perhaps bring that back and bring this research to your Code Blue committee. And I'll send all these out with the links so that you can also provide them for your Code Blue committee. So this one had to do with delays in CPR, defibrillation, and epinephrine, and how it looks for survival. And again, and here we're using Get With the Guidelines, so they are actually looking at 57,000 patients with 9,800 surviving, or 17%, so they're looking at multiple years out of Get With the Guidelines. Times to initiation of CPR greater than 2 minutes. I've got to move this. I've got a thing over the top of it. So greater than 2 minutes were associated with a survival of 18% as compared to 15% for 3 to 5 minutes. It makes a difference. You've got to get the CPR started immediately, and I think some of this, having worked in hospitals for quite a long time, has to do with that confidence and competence in CPR for the bedside nurse or other people while they're waiting for the code team to arrive. I've actually seen nurses hide when a code is called. So very important. And so that's kind of CPR. So we know delays the initiation of CPR and CPR to defib or epi when it's non-shockable were associated with lower survival. So I encourage you to look at this article. All right. Now, there's a few publications of interest I want to point out to you, and I'm going to try to just link into these so that I can show you, but these are all links. When I send this out, you'll be able to actually go, I think this will work. Aha. Some of them have ads, sorry about that. But just confirming, Audrey, you can see that screen?
Yes, we can see it.
Okay. Okay. So this is very interesting. This was assessment of rapid response teams, and you may call them a RAT team, a MET team, so on and so forth. They looked at the top performing hospitals in cardiac arrest and wanted to know, what do these hospitals do that's different than the non-top performing hospitals? And so they looked at 158 hospitals, 158 stakeholders. There were 9 Get With the Guidelines resuscitation hospitals. So this is a Get With the Guidelines assessment. And I'm just going to pop down here. They looked at who's on those teams, nurses, physicians, clinical staff. They also talked to administrators. They have people at each of these teams who talk specifically about their rapid response teams. And in the conclusions, the results are very interesting, but it was important to note that the top performing hospitals, they actually had dedicated staff without competing clinical responsibilities. And I know you're thinking, well, they'll never do that at my hospital. The important part of this, and you can read through, is that not only did they respond to patients in a code or in a respiratory arrest, but they rounded on patients who were at highest risk. So they actually risk stratified their patients, and proactively the rapid response teams went to see those patients with the goal, of course, to be preventing those cardiac arrests. So very interesting study. Okay. And this is interesting. They took the same data and actually added some more details to it. I'm not going to click into that one, but you might be interested because they went more in detail in terms of the specificity of what those top performing teams are doing. Oops. All right. Now here's one. Hospitals with more active participation in mock codes have improved survival after in-hospital cardiac arrest. And this makes sense, right? And some of you are in very small hospitals, and it is going to be critical that you have mock codes. The issue is that if you're not having a lot of them, you actually have to mock code more often than perhaps others. So here we are with this article from Resuscitation. This is out of Europe. And down here. And as you look at this, they looked actually at, I was trying to think what the N was here. This was 26 hospitals. Again, they used Get With the Guidelines. But if they were in the healthcare system and they were actually doing more mock codes, and let me just tell you, I'll pop it out of here, 42.8% survival compared to 31%. Now, these were pretty high-performing hospitals already, and yet they made that much difference in terms of having mock codes. If you are not having mock codes, please encourage your lead of the Code Blue team to get those going. And for those of you who are on RQI, I believe that the mock code situations have been loaded into the RQI system now. So they'll actually you can do mock codes with your RQI stations. Kind of interesting because, we're talking about cardiac arrest. And so this article indicates that it's possible that these numbers we're looking at, that that we're not catching all of the cardiac arrests. So I thought this was interesting because they'll always tell you, and I even told you, I think in an earlier slide, that there's 200,000 cardiac arrests. Well, what this study looked at is that when you're looking at pulseless and things that have different sorts of rhythms, that it's possible that there's actually 38% more adult and 18% more cardiac arrests in the country because of the way we're studying them. If you've ever tried to run a list of your cardiac arrests, then you know exactly how this has happened, because it is very difficult. As opposed to other things, you are not able to run them by a particular code, by a particular ICD. It's very difficult to get this data. So we may even have more than we thought. So we'll want to be aware of that and keep working on it, because there's more people. Very interesting. You may know what the UN-10 rule. This is a rule that was created, when do I stop CPR? And all through clinical work, we've always known that we had this guideline. And for those of you who haven't been involved, or if you're just abstracting, there's 3 guidelines that are normally used to determine if you should stop CPR. That it was unwitnessed, so you came in and they wasn't seen when they went down. That it was a non-shockable rhythm, and there was no return to circulation in 10 minutes. And the concept is, if all 3 of these are there, then that is a guideline you can use to stop the resuscitation. Interestingly, what they found in this, and so you might look at what your hospital's policies are related to this, or at least visit with this. And of course, this took into account how they came out neurologically as well, because we all know we don't want to survive if we're not okay neurologically. So patients who met the UN-10 rule, they were associated with unfavorable neurologic status, and we know that, and they have low rates of survival. However, their survival rates were higher than reported in the initial study, raising the question of whether this rule may have limited utility. So it's just something to think about. A lot of times in research, we're just picking up questions that, things that need further study. Okay, back to I don't know what's going on with my screen here. All right. So sorry. All right. Oh, airway management, a retrospective cohort study of hospital variation in airway management. And they did take this one from Get With the Guidelines. So again, this is why we're so appreciative to each of you for putting data into Get With the Guidelines. It not only helps you improve quality, but if you would all stop sharing your data, the data that was in our CPR originally and then has become Get With the Guidelines resuscitation, much of our research would be stymied. We wouldn't be able to move ahead. So thank you so much for being a part of that research. So the concept with this story was really to look at how many different ways the rate of intubation is and how it reflects on their survival. And in this article, which I don't think, it's intuitive to me, but the patients that had more intubation during CPR, of course, had a lower survival rate. Well, those are also sicker patients. So I do think that, and what they say out of here is identifying the optimal approach to airway management may have significant impact. So it's an important area. So you might go back and look at your policies and your procedures and what your evidence is based on, what your policy is in your hospital through your Code Blue committee as it relates to airway management. And I do want to thank my colleague from the Midwest region, Art Miller. He actually did this literature search. He put that little newsletter, and so I don't want to take his credit. He's the one who put those together. Audrey, any questions?
No questions so far.
All right. All right, want to let you know about some fantastic webinars that are available. When you get this, the link that's in here is actually a link to that webinar page, but we have some wonderful programs that you can look at. One that's really looking at in-hospital incidents. You're going to be hearing this much more. I think it's going to be added. We want to be evaluating the incidence of cardiac arrest that happen in non-ICU settings. And the European Collaborative for Resuscitation has selected this as a national core measure. I expect that we will also. And so we need to look. We believe that 2% or fewer of cardiac arrests should happen outside an ICU setting. So you might start looking at where your cardiac arrests are happening, because if they're happening outside of a highly monitored setting, that is something you can impact. So do watch the video. There's slides available also for that. That's the bottom one. Also, hospital rates of delayed epinephrine. This is a further look at that study that I gave you in paper. The video is available as well as the slides. And then physiologic directed CPR, another good webinar that's available for your review. Upcoming, the American Heart Association's Resuscitation Scientific Sessions. It happens along with scientific sessions. So if you're able to be in Philadelphia for the November 16th and 17th, that will be resuscitation only. It's included in your registration for scientific sessions, which goes one additional day. So if you are able to go to that meeting, there's great science to be shared, but we also have a wonderful opportunity for you. It's called the Get With the Guidelines Quality Showcase. Everybody knows Showcase. I think they use Come On Down here somewhere. But this is going to be a poster recognition and networking event. So if you've been recognized, if you received a recognition last year, we will be recognizing you at this reception. Also, you have the opportunity to put a poster in. And this isn't going to be a poster that's in the bigger scientific session. That deadline was June 6th. But this is a poster that just shows us one of your process improvement programs that you've done through resuscitation. If you've been working with your Code Blue committee and have made some inroads, we will help you put together a poster, and you should submit it to this showcase. And we will have awards. We've done this the last few years, and now we're expanding it. People bring their posters. You might even have these done from other events, and you basically compete to be the winner. We'll have 3 awards. We'll get, of course, recognition, as well as we give multiple Amazon gift cards. That way, if you have 3 or 4 people working on it, you can split up the proceeds. So I encourage you to think about either just attend and look at if you're going to be at scientific sessions anyway, we really want to see you there. You don't have to present to attend. Or take one of your PI initiatives and let's make it a poster. We'll help you with it. Compete for some of these great prizes. So this will be in the response for this meeting that Audrey sends out. The deadline for the posters is October 27th. So you've got plenty of time to just take one of your process improvement initiatives and show it to the world.
Hey, Sheree.
I encourage you to do that. Yes.
We did have a question. Brenda wrote, say that again. Europe is looking at cardiac arrest outside the inpatient area. Do you mean like a procedural area?
No. Cath lab would still be considered really what they call it, and I don't know if you've heard this word in Europe, they happen on the ward. So they like to use that. Cath lab is not considered in that. It's really your inpatient units, anything that would happen on orthopedics, for instance, on a post-surgical patient in med-surg. So, Brenda, it's your non-critical care. With the cath lab and other things that have physicians available, those are not included. Now, it's possible if you were having some in non-physician evaluated places, like with someone having mammography or something like that, that those will be included. But mostly we're looking at ward percentages. Does that make that clear, Brenda? Just type in there if you need more on that. And so we will be asking you guys for your, just a second, I've got a dumb call coming in on my phone. I've got to get it. Okay. All right. So you will be asked to tell us where your cardiac arrests are happening. So when you collect that information later this year, we may be asking you to provide that so we can give you a report that compares you to the country. So I would call it non-critical care percentage. And like I said, we expect the hospitals that are working on this right now have been able to have around 2%. Did you type other things? I guess I could see that probably.
Yeah, she said thank you.
Okay. This is important. This is what is going to be publicly reported in Europe, and it's likely that we will push for cardiac survival to be published here as well, published publicly, as well as your incident rate of out of critical care cardiac arrest. Any other questions, Audrey, that are on there?
No questions.
Reminder, guidelines on the go. It's free. Throw it onto your phone. You pick what guidelines you want to see. When you open it up, if there's a little pink section on it, it means the guidelines have been updated. The great thing is it takes a 200-page guideline statement and tells you what you need to know. Top 10 things you need to know, because if you've ever said, I'm going to review those guidelines, they're really overwhelming. So encourage you to have this on your phone and to tell your docs about it as well. Some important dates. The end of November, your Q3 data should be abstracted. And then this is a leap year here, February. All the 19 data is due to be abstracted, so you're completely done. That gives us a month to look at data and see if there's anything that we can go back and confirm or that there is documentation. So we'll use February to March kind of as a working point. And then at that time, the data is locked and the awards process is underway. And then in May, the awards will be announced based on 2019 data. So I may end up ending up a little bit early, but we'll send this out. Audrey will give us more specifics in a minute. But any questions or things that you need assistance on, if you want to type those in, we are glad to answer those. You can also contact your director, or you can email swaquality@heart.org and we'll get it to the right person. Audrey, any questions?
We do not have any questions.
Well, I'll turn it back to you and we'll give folks a few minutes back this morning.
Great. Well, thank you, Cherie, and thank you everyone who joined. The slides will be sent out to you within 1 to 2 weeks of this presentation. And again, if you have any questions, just feel free to reach out to Cherie, and have a wonderful day, everyone.
Thanks, everybody. Bye-bye.